My name is Kayla Rogers, and I'm an Education and Outreach Coordinator for the Women's Fund. We are a nonprofit in the Houston area that serves women and girls by providing them with the tools that they need to be advocates for their health. So we do this through focused seminars like today's presentation. We also have opportunities for curriculum-based classes, and we do have free publications. So if you're interested in learning more about the Women's Fund in general, you can visit our website. But specifically for our publications, I've included a QR code and a link as well. Again, all of our publications are free, and once you're on the website, you have the opportunity to put in a publication request for physical copies of the publications. So before I introduce our speaker for today's presentation, I just want to go over a few housekeeping things. The first is that I ask you keep your microphone on mute throughout the presentation so that we can limit any interruptions or distractions. And second, if you have questions at any point throughout the presentation, go ahead and add those into the chat. We are allotting some time at the end for questions. Okay, so getting started, today's presentation is a childhood cancer overview with Dr. Susan Blaney. Susan M. Blaney, MD, is the Elise C. Young Chair in Pediatric Oncology and Professor of Pediatrics at Baylor College of Medicine. She serves as the Director of Texas Children's Cancer Center at Texas Children's Hospital and the Section Chief for Pediatric Hematology Oncology. She is board certified pediatric oncologist whose career over the past 25 years has focused on the development of new agents and therapeutic strategies for children with recurrent or refractory cancer, particularly for those with malignancies of the central nervous system. She has extensive experience in clinical translational research. She served as the vice chair for the Children's Oncology Group, an NCI-funded cooperative effort of greater than 200 leading children's hospitals across North America from 2011 through 2020. Dr. Blaney has also served as the Vice Chair for Research in the Department of Pediatrics, Executive Vice Chair of the Department of Pediatrics, Vice President for Clinical and Translational Research at Baylor College of Medicine, and Founding Director for the Institute of Clinical and Translational Research at Baylor. Dr. Blaney has mentored many pediatric medical students, residents, fellows, and faculty who are current or developing leaders in the field of pediatric oncology. Her influence in the field also extends to numerous advisory roles that she has held throughout her career, including an appointment by the director of the National Cancer Institute to its Clinical Trial Advisory Committee, and service as a member of the National Cancer Institute's Investigational Drug Steering Committee, as a consultant for the FDA's Pediatric Oncology Drug Advisory Committee, and for other leading cancer organizations such as the American Association for Cancer Research and the American Society of Clinical Oncology. She also directs or serves on the scientific advisory board for many of the leading not-for-profit foundations for childhood cancer research. Dr. Blaney has published more than 215 articles in peer-reviewed journals and has authored numerous book chapters. She is the editor of the leading textbook in the field of pediatric oncology and a co-editor for a leading textbook in the field of pediatrics. So as you can see, she is a very accomplished doctor, and we are so excited to have her here today. It is an honor, and we are looking forward to her presentation over childhood cancer overview. So I'm going to go ahead and allow her to share her screen.
Have the opportunity to speak to you today. What I'd like to do is give you an overview of childhood cancer, give you the good news, the history of childhood cancer, tell you where we still have opportunities, and then tell you where we're going in terms of future directions for our patients and their families. So Texas Children's Cancer Center is part of Texas Children's Hospital, and I've been fortunate enough to be at the institution for the past 25 years. It's really a phenomenal place to work and a tremendous resource for the Houston community. So on this slide, what you see is the face of childhood cancer and what inspires me to go to work every day. Wonderful children whose lives are changed in an instant in the lives of their families, but they are stoic and don't question and just get through the journey along with their parents and their families, and they are so inspirational. I learn from them every day. So now we're going to start with the overview of just the Cancer Center itself, so I can give you a little bit of background about it. So Texas Children's Hospital is the largest children's hospital in the world. It's ranked number 3 by U.S. News and World Report. And as you can see, we see a lot of patients, and the institution invests a lot in research every year. And that is how we make the progress that we've made in childhood cancer and other diseases. So within the Cancer Center, we have one of the largest programs in North America. We have over 200 faculty. So just to give you a perspective, just in cancer and hematology, I have more faculty in my section than many department of pediatrics. And there's 1,000 staff member, and everybody that's there is there because of the mission and wanting to make a difference in the lives of children and patients, or children who are afflicted with cancer. We see 4,200 new patients each year, both with cancer and hematologic diseases, and do over 120 bone marrow transplants. We do a lot of research. I have 350 researchers in 47 different laboratories, so that we're not leaving any stones unturned when it comes to finding new and innovative therapies for childhood cancer. And some of those I will share with you towards the end when we're talking about the future directions and where we're going in cancer treatment for children. And we make the progress that we have through research that's both laboratory-based, but as well as clinical. And we have many, many clinical trials so that as we treat children, we as a community can learn what the best treatments are for each disease. So our Cancer Center really has leaders all the way around, but in patient care, our goal is to provide patient-focused, family-centered care. Hopefully none of you have ever been impacted by having a child with cancer, but most of us in our lives are impacted with having a family member or a friend who's diagnosed with cancer. And as you know, it's not just an impact on the patient itself, but it really is a diagnosis that affects the whole family. So at Texas Children's, we want to provide support for the whole child and family. And we do that through expert and collaborative multidisciplinary medical teams. We also have extensive psychosocial care teams with child life and social worker to help children, their siblings, and their families work through the diagnosis and their treatment along the way. And also we have unique arts and medicines programs that help with that and help provide healing in ways that medicine can't. In Houston, our patient population at Texas Children's reflects that of the community, and we have one of the largest and most diverse pediatric populations in the country. And because of the innovative work that we do, we see children from all states across the U.S. and across the world. And we have experts to advise patients on the most rare cases that can occur in the realm of pediatric cancer. So our mission is to provide personalized, high-quality, family-centered care to children, adolescents, and young adults with cancer and blood disorders, to discover and implement innovative laboratory research and treatment advances aimed at curing and preventing childhood cancer and blood disorders, and to provide world-class training and education for current and future leaders in the field. We don't make progress by just doing the status quo. We have to have discovery and research, and also to train so that we can advance the field. So now I'm just gonna step back and change directions a little bit and just tell you some facts about pediatric cancer. So unfortunately, pediatric cancer remains the leading cause of death from disease in children. 1 in every 330 Americans develops cancer before the age of 20. And 1 in 750 20-year-olds alive in the US today is a survivor of childhood cancer. To put it in a different perspective, there's about 12,500 children in the US who are diagnosed with cancer every year, which is the equivalent of 2 classrooms a day. And the survival rates will have risen, or the survival rates have risen from 5% over the past 50 years to now almost 80%. 75% is a little bit low. It's closer to 80%. So we have made tremendous progress. So, you know, the first thing parents and families want to know when their child is diagnosed with cancer is, why did this happen? What did I do? They look to, you know, to blame themselves or to figure out, should I have done something different when I was pregnant, or should I have not, you know, lived in this particular area? But the bottom line is that most childhood cancers are spontaneous. There's nothing anybody did to cause them. There's nothing that you could have done to prevent them. Very few are related to environmental factors. We'll talk about that briefly. But for the most part, the environment itself today, from what we know, is not a cause of childhood cancers, in contrast to adult cancers, where we know that things like smoking, asbestos, other factors do cause cancer. So some of the known risk factors for cancer are ionizing radiation. In the past, even before my time, patients used to get routine radiation for fungal diseases of the scalp or other conditions. And it wasn't until many years later that they realized that that could cause cancer. Fortunately, we don't do those things anymore. And when children have x-rays, their gonads and organs are shielded so that we minimize any risk of cancer from radiation. There are some children who do receive radiation as part of their treatment for cancer, and they do have an increased risk of developing a second cancer as a result of the radiation. But at that point in time, it's a risk-benefit decision because we want to cure the cancer that they have. And as we do research and learn more about radiation modalities and the best way to give radiation, we continue to decrease that risk. There are children who are born with immune deficiencies, and these are very, very severe immune deficiencies that have an increased predilection or risk for developing cancer. And part of your immune system every day helps keep foreign things from the body in check, and cancer is foreign to the body. So when cells start to develop an aberration, the body can recognize them and the immune system can destroy them before they can grow and develop into a cancer. But in patients whose immune system is not working properly, they can develop cancers early in life as a result. There are some inherited conditions that there is a family, and most of these, there is a strong family history. Sometimes they don't realize until a child is diagnosed with cancer that there's an inherited predisposition for cancer. Fortunately, those aren't that common, but when we diagnose a child or family with a predisposition to developing cancer, then we can monitor that family and any siblings very closely so that if they do develop a malignancy, hopefully we can detect it at an early stage. So this is just to give you an overview of the annual incidence of childhood cancer and to put it into perspective with those of adults. And sometimes these numbers, before I told you it was about 12,500, It depends on the age range that you're looking. Some studies look 0 to 18, some to 21, but roughly 10 to 12,000 children a year, depending on that boundaries that you put on that upper age. But the point of this slide is to just put it into contrast with adult malignancies. And you can see that adult cancers by far outweigh the number of pediatric cancers. That being said, the adults have a lot to learn from how we have worked together as a pediatric oncology community to do clinical research and treat children and continue to make improvements in the treatment of cancer. And so progress can be made, things can be learned from the treatment of childhood cancer. The other thing I just want to mention is that the types of cancer that occur in children are generally very, very different than the types of cancer that occur in adults. And children are growing very quickly, especially during the first few years of life. And their cancers oftentimes occur in those organs that have rapid growth. So those are differences in addition to the fact that adults develop cancers related to the environment. So this just gives you a breakdown of the types of childhood cancer. I'm going to show you this in a graphic form in a minute. Some people like numbers better, others like graphical representations. But from here you can see that leukemias by far and away are the most common type of childhood cancer. And those are followed second in incidence by brain tumors. And then there's a whole host of other cancers, lymphomas, which are cancers of the lymph nodes, thyroid cancer, skin cancer, tumors of muscle, tumors of bone, and then tumors of other organs in the body, such as the adrenal gland, the kidney. Retinoblastoma is a tumor of the eye, and liver tumors, and then other very rare tumors. So cancer can occur in almost any organ system, but most commonly occurs in the blood, the bone marrow, which is the leukemia or brain tumors. So this just shows you here graphically. Here you can see in this pie diagram the large number of cancers that are leukemias, and then the large number that are brain tumors. And these are all the other organ systems. There are more than one type of leukemia. And I'll talk about that in a little bit more detail. That's outlined here called AML. But this just gives you a graphic representation of the distribution of childhood cancer types. So this is the good news. We've made tremendous progress in curing childhood cancer. Here you can see in 1960, the dark turquoise cylinders, the cure rate for ALL was less than 5%. And today, that cure rate exceeds 90%. And in fact, in some subtypes of lymphoblastic leukemia, the cure rate is almost 98%, which is really phenomenal. And then here you see a tumor of the lymph node. Again, when I started my training, if you had a diagnosis of a type of non-Hodgkin's lymphoma, most children died. Today, more than 80% of them are cured. And then Wilms tumor, tumor of the kidney, tremendous progress. However, that being said, there's still many opportunities for improvement. The type of leukemia called acute myeloid leukemia, still tremendous progress, but not good enough. It only exceeds 60%. Neuroblastoma, a tumor of the adrenal gland, this probably now exceeds 50% if you look at all different subtypes of neuroblastoma, but still a lot of opportunity for improvement. And unfortunately, this type of tumor called brainstem glioma, also called diffuse intrinsic pontine glioma, now more commonly, we have made no progress in its treatment. So there's tremendous laboratory research in some of these high-risk tumors, other high-risk tumors where we still have opportunities for improvement are those cancers that are metastatic or who is spread at diagnosis. Some types of bone tumors and muscle tumors will commonly be disseminated or metastatic at diagnosis. So there's many childhood cancers, and I'm not going to talk about each one of them today. I'm happy to answer questions about any of them, but we could go on for days if I told you about all of them. So what I want to just do is focus on the two most common ones and talk about leukemias and talk about brain tumors. So acute leukemia, as I mentioned, is the most common type of childhood cancer. There are some kinds of chronic leukemias. Those occur much more commonly in adults than children. But the most common type of leukemia is ALL, or acute lymphoblastic leukemia, and then AML, the myeloid leukemia, and then much less common, very, very rare, in fact, in children, is CML, or chronic myeloid leukemia. So what is leukemia? It's a leukemia of the blood, and it's the white blood cells in the blood that here you can see all these cells that look the same. These do not belong. When you take a blood sample and you look at it under the microscope, these cells should not be here. And what they continue to do is continue to multiply and rapidly increase. They push the normal blood cells out of the bone marrow. There's not room for your normal blood cells to continue to be manufactured. And what happens is children will have pain commonly because of the rapid growth of these cells. They can be very, very anemic because the red blood cells don't develop. And then they often have bleeding because their platelets, which help with clotting, those are very, very low in number as well. And, you know, many, many times children will go to their pediatrician for multiple visits before they're diagnosed with leukemia because the symptoms are so non-specific. And I always say that general pediatrician has one of the hardest possible jobs because cancers, those symptoms often mimic regular childhood conditions. Oh, I don't feel good, or my leg hurts. Or when we talk about brain tumors, they might have some nausea and vomiting. And it's not until their disease is more progressed that you notice, oh, they're pale, or they might have petechiae, little spots on the skin because their platelets are so low and they have these little micro hemorrhages in their skin. Or they could have overt nosebleeds or other things like that. We don't know until we draw a blood sample, or sometimes the blood sample is relatively normal. We actually have to get a sample of the bone marrow to make the diagnosis. But once we do make that diagnosis, we can give the families a lot of hope about what the outcome is for their child, because as I showed you before, the cure rate has improved dramatically. What is the treatment of leukemia? The treatment's intensive. It includes today chemotherapy, and sometimes if it's a high-risk leukemia, patients might get a bone marrow transplant as part of their initial treatment. We're now studying the role of immunotherapy at diagnosis to see if we can decrease the toxicity of our current therapies by giving treatments that are specifically directed at the cancer cells. But as I mentioned before, most children do very well. The duration of treatment for leukemia will depend on the type. It's about 2 years in duration for children with ALL. It used to be 3, but we have found through research that we can reduce it to 2 years. For AML, that treatment is shorter in duration, but it's very, very intensive, and the children will be in the hospital for most of their treatment. The side effects of the treatment can be extensive because when we're treating leukemia, what we do is give treatments that get rid of all these cells in the bone marrow, and it impacts the normal cells as well. What that means is you don't have white blood cells to fight infection, and you have a very increased risk of developing infection, in addition to issues with anemia and bleeding. And here's just another graphical representation of the progress that we've made in the treatment for acute leukemia. And I love this slide because what it shows you, each one of these lines is a clinical trial. And on the x-axis is the number of years from diagnosis. And on the y-axis is the percent survival. And here you can see in 1970, less than 20% of children survived for 10 years after a diagnosis of acute leukemia. And through clinical trials and through research, we have been able to make increasing increments of progress in the overall survival for children who are diagnosed with leukemia. So that today in 2010, or from in 2010 this was, but even today in 2020, now more than 90% of children who are diagnosed with ALL are survivors of their childhood leukemia. So that's phenomenal progress. So I'm sure many of you may have questions about leukemia, and I will answer those if you do at the end. So the next tumor that I'm going to talk about is brain tumors. And what this is that MRI that shows a sagittal section of, if you just took a slice of your brain sideways, and here this is all brain tissue, and these are different parts of the brain. So brain tumors are often, again, very difficult to diagnose. So tumors can occur in any areas of the brain, and we kind of compartmentalize them, and based on these areas, you can have different symptoms. So one of the tumors in the central nervous system, tumors can occur in the spine, and those typically present with pain or weakness. Children can have difficulty walking. If they're very severe and they affect the lower spine, they can have loss of bladder and bowel control. But depending on how aggressive a tumor is, it can take weeks or months to diagnose, because some tumors, some can grow very slowly, and the symptoms just aren't recognized, or a differential diagnosis of tumor isn't made. Now, there's tumors that occur in the back of the brain, and in children, we call this the posterior fossa, this compartment, and the brainstem. The brainstem regulates your heart rate and your breathing. The posterior fossa is the most common location for tumors in children. In contrast, in adults, it's this part of the brain, what we call the supratentorial region. It's much more common. So children who are young, between birth and 7 or 8 years of age, will have tumors in this area, and they can present with balance issues. They're just clumsy and fall all the time, or a child who had been walking now isn't walking very well. There's crawling instead of walking. This back part of the brain can affect your speech, and so children can have speech issues. Or they can have, there's a lot of nerves back here that control your eye movements, and we call them the cranial nerves, your facial muscles. And so they might present with crossed eyes or a lopsided smile because of the impact on the nerves that are in this part of the brain and the tumors compressing. So tumors in the front part of the brain can become very, very large before they're diagnosed, because there's more area to expand. And they typically present with headaches because of pressure. They can present with seizures, and they can also present with the motor strip that control the movements of your arms and your legs are in the front part of the brain. and they can present with a partial paralysis. They usually don't present with a complete paralysis, but you can see the child can't use their hands as well as they used to, or they're tripping because their feet aren't working as well as they used to. And then there's this area in the brain right here called the suprasellar region, and that's where your pituitary gland is, and that regulates a lot of hormones for growth, for puberty, for all the your thyroid. So children who have tumors in the suprasellar region can often present with issues that are related to endocrine problems. So again, very, very difficult for the general pediatrician to sort out what's a febrile seizure, you know, is a child just clumsy? Because in the posterior fossa, I didn't mention, they can often have nausea and vomiting as well. A lot of times they're diagnosed as having a gastroenteritis. And it's not until the symptoms don't get better or they're persistent that an MRI or a CT scan is obtained. So just like leukemias, there's many types of brain tumors, and this is just a breakdown. The most common ones in children, as I mentioned, that are malignant are those in the posterior fossa. Those are called medulloblastomas. And then there's gliomas, and I know you've all heard of glioblastoma multiforme. That's a high-grade glioma that usually occurs in the front of the brain, and those are very, very aggressive. And then there's less aggressive, more indolent tumors like low-grade gliomas and some types of ependymomas that children can have, and they can occur in various parts of the brain. So what is the treatment for brain tumors? Well, part of it depends on the location. Okay, almost all patients will have surgery to try to completely resect the tumor, but that's not always possible. So this tumor called the brainstem glioma, or as I said before, diffuse intrinsic pontine glioma, that occurs in your brainstem. You can't take out the brainstem because that controls all of your vital functions, as I mentioned before, your breathing, your heart rate, etc. And these tumors are very infiltrated. You can see this is tumor in here. You can't differentiate normal brainstem. Here's a normal brainstem here from the tumor. It's just all together. In the past, this was just a radiographic diagnosis. We just saw the scans and made the diagnosis and initiated treatment with radiation. Today, with the advent of precision medicine, we will biopsy some of these tumors to see if there's a molecular aberration that might be targeted by one of the new treatments that we have. And then there's high-grade gliomas, medulloblastomas. These are the posterior fossa. This is a different slice of the brain. But for these types of tumors, the last two, we do surgery for almost all the patients. Many of them will get chemotherapy. There are some rapidly growing tumors where there's an indication for stem cell rescue, which is a bone marrow transplant, using the patient's own blood cells. That does not happen very commonly in brain tumors, but it's possible. And then many tumors still, for example, this one that we can't surgically remove, some medulloblastomas and some high-grade gliomas we treat with radiation therapy. Radiation is a treatment that can have a lot of side effects, particularly on the developing brain. So for patients who are less than 3 to 5 years of age, we don't give them radiation. We try to give them more intensive chemotherapy. For other children, they do receive radiation. Radiation has changed a lot over the past 20 years. Now we can do more targeted radiation so that the radiation is just treating the tumor bed without a lot of scatter to other normal tissues. And I'm sure that most of you have heard of proton radiation therapy, and that causes less damage to the normal surrounding brain. When you give radiation, there is scatter. So it doesn't just stop here where the tumor is, there's still radiation. that is not as intense as the whole tumor gets, but they're still scattered. And so using proton radiotherapy, there is less damage to this normal surrounding brain. And we've done a lot of studies in that to look at proton versus traditional radiation, and we've demonstrated that indeed is the fact. So this just shows you for, again, an opportunity. This is the DIPG. These are two different clinical trial groups. These are what we say contemporary trials. They've occurred in the past 10 to 15 years. And here you can see, again, the probability of survival on this y-axis. And here it's not years from the start of therapy. This one is months. That most children who are diagnosed with this tumor, even with radiation therapy, do not survive 2 years beyond their initial diagnosis. So needless to say, this type of tumor is a very high priority for our research studies. So what I just want to spend the last 10 minutes or so talking about is future directions for childhood cancer treatment. What are our goals for the future? First, we want to decrease the short and long-term side effects of treatment. And obviously, we want to increase the cure rates. We've made tremendous progress. I said more than 80% of children are cured, but that's not good enough. That means still that there's 20% for whom we don't have curative therapy. So what is our approach to doing this? So our approach is to use precision medicine, which I'll talk to you about in a little more detail, immunotherapeutic approaches, which incorporate precision medicine, and then to keep doing clinical and laboratory research so that we can bring the results of these studies into trials to continue to make the kinds of improvements that I showed you with acute lymphoblastic leukemia. So this just is a slide that shows you that when a child is diagnosed with cancer, the majority of them at some point during their treatment will experience a life-threatening toxicity. There is a small number that develop, unfortunately, fatal toxicities, but only a very, very small sliver who have mild toxicities. So you can see by far and away, most children will have moderate, severe, or life-threatening toxicities, and these toxicities can affect any organ system in the body. Some of these toxicities are the day or two after chemotherapy. They quickly get better, like nausea and vomiting, but some of them can impact the heart or the lungs or the kidneys, and they may not be manifest till 5, 10, 20 years after diagnosis. So when children go through cancer treatment, we continue to follow them based on what their therapy was for the rest of their lives to monitor them for potential toxicities and to try to give them preventative treatment if we see early signs, for example, of heart damage. But the biggest thing that we want to do going forward is to be able to minimize or to prevent such toxicities. So how do we do that? Well, in the laboratory, we have learned so much about each tumor type, and I'm just going to give you a few examples. So medulloblastoma, the most common malignant brain tumor in young children. When we look under the microscope, they almost all look the same. But when we do molecular studies, and these advances in the field have only been possible during the last 10 to 15 years, we find that medulloblastoma under the microscope isn't one disease, it's 4 different subtypes of disease. And based on the subtype, so these are the 4 subtypes, the survival is different. So patients with the Wnt subtype of medulloblastoma, here you can see their survival. I'm sorry, this is survival again on the y-axis. almost all of them survive. When doesn't occur in young children, but children and adults, rarely adults get medulloblastoma. They have a good prognosis. But if you have this type that has the molecular characteristics of group 3, here you can see many of these tumors, you don't see this here, but many of them are metastatic at diagnosis, and their survival is much worse, really somewhere between 20 and 40%. So how does that help us? Well, it helps us to treat the different subtypes differently. If you have a tumor with a good prognosis, there's a good chance that just taking it out surgically is going to be treatment enough, and that you may not need intensive radiation therapy or chemotherapy. And so now that we know this by looking at the biology of the disease, we can do trials to incrementally decrease the treatment that we give and carefully monitor to make sure that we're not compromising this excellent outcome rate. So that's what that's how we use this information that we learned from the laboratory. And this is just a different way to show you that based on biology, sometimes it also, here in infants, there's no Wnt, but in children, there is a big subgroup, or relatively big, that probably have a good prognosis, probably don't need radiation and may not need chemotherapy. And these group 3 tumors that are more aggressive, we can intensify their therapy or look at the molecular aberrations and see if there's something we can target with precision medicine to help increase the outcomes or improve the outcomes for those patients. So across the board, when children have tumors that come back, our approach today with precision medicine is to do a tumor biopsy, do genome sequencing on the tumor, see if there is an aberration in the tumor that we can target with a drug that will prevent the tumor from continuing to divide and grow. And then based on that mutation, we have trials now where there's a whole bunch of different drugs, and then we can match the patient's tumor to the type of drugs, the study agents, these are all investigational that we have available to see if it will improve, make the tumor either stop growing or hopefully shrink. And that's what we do. We match the study agent. We monitor the patient closely to see if they have a response. If they have a response, and a response can be no tumor growth to a complete response, then we continue the drug until their tumor grows again. When it grows, we study it in the laboratory again, because when tumors grow and divide, they can develop new mutations, and maybe there is a match on the tumor. That's how they become resistant, and if there is, they go back into this loop, and if there's not, then they leave this particular study. But this is a common treatment paradigm now, that we know that all tumors are not the same. They might look the same under the microscope, but they may have very different features at the molecular level. And this type of trial design, it's amazing how if you have a very precise match or a drug that inhibits the target, we are now seeing children who have highly resistant tumors that sometimes have complete responses to the new drugs that are available by using this treatment paradigm. And that is so amazing to see when you've seen these children years after year after year and not have anything to offer the family. And now is a time, I think, of great hope and discovery for patients whose tumors are resistant to standard treatments. And this just shows you at Texas Children's. Actually, this whole treatment paradigm was developed by 2 of my faculty, Dr. Will Parsons, who's a cancer genome expert, and Dr. Sharon Plon, who's a genetic researcher in cancer. And they were the first investigators in the country to be awarded by the National Genome Institute to bring this type of molecular diagnostic testing to the clinic. It used to be a research tool only, and now we use it when we see our patients and their tumors are biopsied every single day. Their first study was very, very successful. They have now gone on to get a study that has been funded by the Cancer Prevention Research Institute of Texas. And the goal of this study is to see if we can use these same tools no matter where across the state a child is diagnosed, even if they don't have access to a center like Texas Children's, to be able to do this testing so that children can get treated close to home and get the best possible care. And this initial study has led to all kinds of downstream studies, like that MATCH study that I just showed you, which is a national study that's being done across the country. And they've advised, the president's Moonshot Blue Ribbon panel, the FDA, and many other investigators. But we're just very fortunate to have some of the best and the brightest minds right here at Texas Children looking and developing these new treatment paradigms for our children who are afflicted by cancer. And then likewise, we have a world-class immunotherapy group. Just take a few minutes to talk about what is cancer immunotherapy. It's a form of treatment that uses the immune system to target and destroy cancer cells. As I said earlier, the immune system attacks and destroys new and foreign substances in the body, such as viruses, bacteria, or cancer cells. And how does that work? Well, cancer cells, what they do is they develop alterations that prevent the immune system from recognizing them and to make them not susceptible to destruction. So what we're doing is developing immune therapy so that this doesn't happen. And there's many strategies that are being evaluated across the country and within our own center, but what I'm going to focus on is these cell therapies. So before I do that, I just want to say that, the beauty of cancer immune therapy is that ideally it just selectively kills the tumor cells and doesn't impact the normal cells. And likewise, if it just attacks the tumor cells, it can be effective both against local as well as any metastatic disease. And sometimes there's micrometastatic disease that scans don't detect. So there can be cells circulating in the body, and the immune-based therapy, we have an opportunity to get those cells before they grow and develop in another site. And I think that you're all aware, you see it in the news all the time, that using immunotherapy has really revolutionized the way we think about cancer and how to treat it. And I believe that in the future that treatment will, hopefully we'll get away from using radiation therapy and being able to lessen the intensity of the chemotherapy and combine relatively low dose chemotherapy with immune-based approaches to minimize the risk of toxicity and increase the opportunities for cure. So T-cell immune therapy, and a lot of times you'll hear this as CAR T-cell therapy. CAR stands for chimeric antigen receptor. What happens is we collect blood from the patient, just like when you go to the doctor's office and have routine blood work. We collect a sample of blood. We take that blood to the laboratory, isolate the T cells, which is a form of white blood cells, genetically modify them in the laboratory. Okay, here's the T cell. We modify it in the laboratory to have what's called a chimeric antigen receptor. And this receptor, what it does is it will attach to or recognize something on the cancer. And we know what types of receptors to put on these T cells based on those genomic studies and genetic studies that we do in the laboratory. And once these cells are modified, and sometimes they'll have signals to activate them, they then go, once they're infused back into the patient, they'll go and destroy or kill the tumor cells. And the way we give them back to the patient is the same way we got them out. We just put in a small IV and infuse them back into the patient. And at Texas Children's, we have what's called a good manufacturing facility to make these cellular therapies right in our building and be able to give them back in patients. There's not many places in the country that have those facilities available. So we have patients that do come from all over the country to get some of our cellular therapies. And I just want to show you a few examples early on in the development of some of these therapies, the phenomenal success that we've seen in patients with highly resistant and relapsed disease. So here in this scan, you see tumor, and after the T-cell treatment, there's no tumor. Some of these other things that light up are normal signals. They're not tumor. So I just want you to, so this is the tumor here. Here's another example in a patient with a brain tumor. Brain tumors are very, very difficult to treat, especially these high-grade gliomas. Here's a patient pre-infusion, and only 6 weeks after treatment, we see a marked reduction in the tumor. And this is pretty amazing because this is a tumor because of its location is not surgically resectable. Another example of a patient with a type of a tumor called a neuroblastoma that has metastasized to another area of the body, okay, the sternum. And again, this is the first patient on the study, and just after one treatment, you can see a marked reduction in the tumor signal. And then lastly, this is a patient who had metastatic muscle tumor, which is historically not curable. He was treated with a CAR T cell targeted to something called HER2. HER2, many of you may have heard of because it occurs in breast cancer. It can occur in other tumors as well. And after treatment, now 2 years, his tumor is gone. Now his tumor did initially come back, and he was retreated several times with this T-cell therapy, and the patient is still alive and doing very well. So I think that just to summarize, cancer, when people think of cancer, we all just take a big sigh and think of the worst, but we have made tremendous progress across the board with just a few exceptions. But we have a lot of hope for future progress based on the power of what we're able to do in the laboratory now and how we're able to harness the immune system and to learn more about precision medicine and make more targeted therapies for our patients. So we're very, very hopeful, and I will stop there and see if you have any questions.
Okay, thank you so much for that wonderful presentation. I am going to go ahead and start in. We do have a few questions. So the first is, my grandson, who is almost 18, has constant nosebleeds and has a regular cough, phlegm every morning, which sometimes results in nausea and throwing up. Both parents are chain smokers to which he has been exposed since birth. Should we be concerned?
So I think the first thing is I would just have an evaluation by the pediatrician. There's many, many things that can cause chronic nosebleeds, and most of them would not be cancer. Obviously, smoke is an irritant, but if this is a change or they're not stopping, I would certainly make sure that your grandson is evaluated by his pediatrician.
Okay. The second My daughter Emily is a social worker in neuro-oncology at Texas Children's Hospital and loves her patients, her doctors, and entire team. She always tells me that this is such an honor to work with such special children and their families during this daunting time of their lives. I guess that was just kind of a compliment to the Texas Children's.
Yeah, we're so, you know, our whole team is really incredible, and we're so fortunate to have wonderful nurses, pharmacists, child life workers, social workers. It really does take an incredible team to give our children and the families the kind of care that they need and that they deserve. So tell her thank you for everything she does. The doctor alone is definitely not enough.
Okay. Next question is, when someone is diagnosed with cancer, the cost of treatment is often a huge concern. Is immunotherapy a more or less cost-effective treatment option?
So that's an excellent question. Today, immunotherapies can be quite expensive. For clinical trials, the patient isn't charged for the products in the clinical trials, usually if it's investigational. However, there's many resources to help families because what we do is take care of the patient first and make sure that we can help them with whatever assistance they need to get the treatment that they need. So there is one immune therapy, for example, for leukemia that is now commercially available. And companies will often have programs where we can apply for patients whose insurance won't cover it for whatever reason to be able to make the product available for them. So we always worry about the child first, and other details, you know, get worked out. And I would say the Houston community is also very generous in terms of its philanthropic support for our patients who have needs.
That's great. That's great. Okay, so the next question. You mentioned that radiation as a treatment option for brain tumors is usually used for older children and not younger children. Are treatment options for leukemia vastly different for children based on their age? For example, would leukemia treatment for a 10-year-old be different from that of a 4-year-old? And does the immune system development play a role in that?
So, great questions. So, I would say the treatment for a baby, like somebody less than a year, would be very different than the treatment for a 4-year-old or a 10-year-old, but that's based on the type of leukemia that they develop. So just like I showed you all the subtypes of brain tumors that we have, well, leukemia, we have many subtypes of leukemia, and we tailor the treatment for the child's leukemia to the underlying biology of their disease. So it's really not going to depend on their age at that point. It's going to depend on their biology. And so a 10 and a 4-year-old may get the very same treatment. Sometimes children that are older have features of their leukemia that put them at higher risk and may require more intensive treatment, but it's not 100% across the board. We look at every single child and their tumor and make the recommendation based on the biology of their tumor.
Okay, thank you. And the last question here, there is a link between smoking and leukemia in adults. Has there been any link to secondhand smoke exposure and leukemia in children?
So, to the best of my knowledge, there's not. The smoking, I think, takes much longer exposure. So in young children, there's not links to the best of our knowledge. But we have a very strong epidemiology group at Texas Children's as well, and they're always looking at, things like environmental exposures or other genetic predispositions that may occur in different race and ethnicities that might increase or decrease a patient's risk of developing cancer or their risk of toxicities related to treatment. So sometimes we tailor the treatment based on the underlying genetics of the patient, because we know that there's some drugs that some groups of children won't tolerate as well as others. And they're going to have more side effects. We want to find a different way to treat them.
Right, exactly. Well, thank you so much for your time.
Thank you.
It was a wonderful presentation. If any